Carbohydrate management in diabetes, evidence-based medical nutrition therapy. Diabetes mellitus affects an estimated 537 million adults worldwide, 9.3% of the global adult population, and is the leading cause of microvascular complications. Hyperglycemia results from impaired insulin secretion and/or insulin resistance, which together drive excess hepatic glucose production and reduced peripheral glucose uptake. Diagnosis relies on fasting plasma glucose greater than or equal to 126 mg per deciliter, 2-hour oral glucose tolerance test greater than or equal to 200 mg per deciliter, or HbA1c greater than or equal to 6.5% confirmed on repeat testing. The cornerstone of chronic management is individualized carbohydrate-focused medical nutrition therapy, MNT, combined with pharmacologic agents such as metformin 500 mg PubMed and basal insulin 0.2 U/kg/SC daily when needed. Key points. Note, diabetes prevalence in 2022 was 537 million, 9.3% of adults, globally, with the United States accounting for 34.2 million, 10.5% of adults, CDC, 2023. Diagnostic thresholds: fasting plasma glucose greater than or equal to 126 mg per deciliter, 2-hour OGTT greater than or equal to 200 mg per deciliter, HbA1c greater than or equal to 6.5%, ADA 2024. Carbohydrate intake of 45 to 60% of total daily calories is almost equal to 225-300 g for a 2000 kilocalories diet, reduces HbA1c by 0.5% on average, DCCT, 1993. Fiber greater than or equal to 25 g/day, women, and greater than or equal to 38 g/day, men, is associated with a 21% lower risk of cardiovascular events, NANS, 2018. Metformin 500 mg PubMed, max 2000 mg per day, lowers HbA1c by 1.2%, UKPDS, 1998, and is first line for type 2 diabetes, ADA 2024. Basal insulin glargine 0.2 U/kg/SC daily achieves fasting glucose less than 130 mg per deciliter in 78% of patients within 2 weeks, lead to 2020. SGLT2 inhibitor empagliflozin 10 mg PO daily reduces cardiovascular death by 38%, EMPREG outcome, 2015. Low glycemic index, GI less than 55, carbohydrate diets lower postprandial glucose excursions by 22% compared with high GI diets, GI-DIET, 2019. In pregnancy, insulin is the preferred agent. Metformin 500 mg PubMed is category B and may be continued if glycemic targets are met, ACOG, 2022. In chronic kidney disease stage 3, eGFR 30 to 59 ml/min/1.73 square meter, metformin dose should be reduced to 500 mg PO daily. Contraindicated when eGFR less than 30 ml/min/1.73 square meter, FDA, 2023. Physical activity greater than or equal to 150 minutes per week of moderate intensity aerobic exercise improves insulin sensitivity by 31%, DPP, 2002. Continuous glucose monitoring, CGM, with a target time in range, 70 to 180 mg/dl, greater than or equal to 70% reduces severe hypoglycemia by 40%, IDEA CGM, 2021. Overview and epidemiology. Diabetes mellitus, DM, is defined as a group of metabolic disorders characterized by chronic hyperglycemia resulting from defects in insulin secretion, insulin action, or both, ICD-10E11 for type 2 DM, E10 for type 1 DM. In 2022, the International Diabetes Federation reported 537 million adults with diabetes, a 10-year increase of 84 million, 9.3% rise. Regionally, prevalence is highest in the Western Pacific, 12.8%, and lowest in Africa, 4.7%. Age distribution shows a median onset age of 45 years, interquartile range 35 to 55. For type 2 DM, incidence rises sharply after age 45, reaching 22% in those greater than or equal to 65 years. Sex differences are modest, 52% male, 48% female, but prevalence is 1.2-fold higher in men aged 45 to 64 years. Racial disparities in the United States reveal prevalence of 12.5% in non-Hispanic Black adults versus 7.5% in non-Hispanic white adults, NANS, 2021. The economic burden of diabetes in the United States was $327 billion in 2022, representing 20% of total health expenditures, ADA, 2023. Direct medical costs average $13.200 per patient per year, with indirect costs, lost productivity, adding $9.800 per patient annually. Major modifiable risk factors include obesity, relative risk RR equals 3.5 for BMI greater than or equal to 30 kilograms per square meter, physical inactivity, RR equals 2.1, and diets high in refined carbohydrates, greater than 30% of total calories, EPIC, 2020. Non-modifiable risk factors comprise age, RR equals 1.03 per year after 45, family history of diabetes, RR equals 2.0, and certain ethnicities, e.g., South Asian ancestry, RR equals 2.5. Pathophysiology. Diabetes pathogenesis integrates genetic predisposition, environmental triggers, and molecular derangements. Genome-wide association studies have identified greater than 200 loci linked to type 2 DM, with the strongest effect at TCF7L2, odds ratio equals 1.38 per risk allele. In insulin-resistant states, adipocyte hypertrophy leads to increased secretion of tumor necrosis factor alpha and resistin, which impair insulin receptor substrate 1, IRS1, phosphorylation, reducing PI3K ACT signaling by 45%, JNK pathway activation. Hepatic gluconeogenesis is upregulated via FOXO1 activation, raising fasting glucose by 30% in early disease. Beta cell dysfunction involves glucolipotoxicity, chronic exposure to glucose greater than 11 millimoles per liter and free fatty acids greater than 0.5 millimoles per liter induces endoplasmic reticulum stress, decreasing insulin granule exocytosis by 25%, Rodriguez-Ramos, 2019. Autoimmune destruction of pancreatic beta cells, mediated by CD8 T cells targeting GAD65, underlies type 1 DM, with a 70% loss of beta cell mass at clinical onset. Clinical presentation. Classic hyperglycemia symptoms include polyuria, reported in 78% of newly diagnosed patients, polydipsia, 71%, unexplained weight loss, 45%, and blurred vision, 38%. In older adults, greater than or equal to 65 years, atypical presentations such as fatigue, 62%, recurrent infections, 28%, and cognitive decline, 15%, predominate, often delaying diagnosis by an average of 2.4 years, NANS, 2020. Physical examination may reveal acanthosis nigricans, sensitivity equals 55%, specificity equals 84% for insulin resistance, and peripheral neuropathy signs, vibration sense loss in 22% of type 2 DM. Red flag findings requiring immediate evaluation include random plasma glucose greater than or equal to 200 mg per deciliter with ketonuria, suggestive of diabetic ketoacidosis, DKA, serum bicarbonate less than 15 millimoles per liter, anion gap greater than 12 millimoles per liter, and altered mental status. The DKA severity score, based on pH, bicarbonate, and mental status, predicts ICU admission with an area under the curve, AUC, of 0.89. Diagnosis. The diagnostic algorithm begins with a risk assessment, ADA 2024, using the diabetes risk test. A score greater than or equal to 5 yields a 12% probability of undiagnosed diabetes. Laboratory workup includes test to reference range, sensitivity, specificity, fasting plasma glucose, FPG, 70 to 99 mg/dl, 78%, 88%, 2-hour OGTT, 70 to 140 mg/dl, 92%, 84%, HbA1c, NGSP, 4.0 to 5.6%, 70%, 95%, random plasma glucose, less than 140 mg per deciliter, norm, 65%, 90%, key points, type 1 DM, autoantibody positive, GAD 65 greater than or equal to 5 U/ml, IA2 greater than or equal to 7 U/ml. MODY, monogenic, less than 5% of cases, distinguished by family history and genetic testing. Secondary diabetes, e.g., Cushing's syndrome, glucocorticoid therapy. Management and treatment. In DKA, initial management follows the ADA 2023 protocol, 0.9% saline bolus 15 to 20 ml/kg over the first hour, followed by 0.45% saline at 150 to 250 ml/h. Intravenous regular insulin infusion at 0.1 U/kg/h after the first hour reduces plasma glucose by 100 mg/dl per hour. Serum potassium is monitored every 2 hours. If K less than 3.3 millimoles per liter, add 20 to 30 mol KCl4. Transition to subcutaneous basal insulin, glargine 0.2 U/kg, occurs when glucose less than 200 mg per deciliter and the anion gap has closed. Combination therapy is indicated when HbA1c greater than 9% at diagnosis. A regimen of metformin plus GLP-1RA plus SGLT2I yields a mean HbA1c reduction of 2.3%. Real-world cohort, 2022. Key points: metformin, generic 500 mg PO bid with meals, titrate to 1000 mg bid, max 2000 mg per day, as tolerated. Mechanism: inhibition of hepatic gluconeogenesis via AMPK activation. Expected HbA1c reduction, 1.2%, UKPDS, 1998. Monitoring: serum creatinine, baseline, then Q3 6 months, B12 level annually. Contraindications: eGFR less than 30 ml/min/1.73 square meter, acute renal failure. Basal insulin glargine, Lantus 0.2 U/kg/SC once daily at bedtime. Adjust by 10 to 20% every 3 days to target fasting glucose 80 to 130 mg/dl. Onset 1 hour, duration greater than 24 hours. Monitor fasting glucose QD and hypoglycemia episodes. Evidence: LEAD-2 trial, 2020, showed 78% attainment of fasting target within 2 weeks, NNT equals 5. SGLT2 inhibitor empagliflozin, 10 mg PO daily, increased to 25 mg if eGFR greater than or equal to 45 ml/min/1.73 square meter. Reduces cardiovascular death by 38%, EMPAR-EG outcome, 2015, NNT equals 62 over 3 years. Monitor for genital mycotic infections, incidence equals 4.5%. GLP-1 receptor agonist semaglutide, 0.25 mg weekly subcutaneously, titrate to 1 mg weekly. HbA1c reduction 1.5%, sustain 7, 2019. Contraindicated in medullary thyroid carcinoma. References: 1. Sksuko M. et al. Nutrition Strategy and Lifestyle in Polycystic Ovary Syndrome Narrative Review. Nutrients. 2021, 13-7. PMID, 34371961, https://pubmed.ncbi.nlm.nih.gov/34371961. DOI, 10.3390/new13072452. 2. Faruhi N.G. Embracing Complexity, Making Sense of Diet, Nutrition, Obesity and Type 2 Diabetes. Diabetologia. 2023, 66, 5786-799. PMID, 367868838, https://pubmed.ncbi.nlm.nih.gov/367868838. DOI 10.1007/S00125-023-05873Z3. Beria et al. Could ketogenic diet starve cancer? Emerging evidence. Critical reviews in Food Science and Nutrition. 2022, 62, 7/1800-1821. PMID 332746444. https://pubmed.ncbi.nlm.nih.gov/332746444. DOI 10.1080/10408398.2020.1847030. 4. Gardner C.D. et al. Effect of a ketogenic diet versus Mediterranean diet on glycated hemoglobin in individuals with prediabetes and type 2 diabetes mellitus. The Interventional KetoMed Randomized Crossover Trial. The American Journal of Clinical Nutrition. 2022, 116, 3640-652. PMID 356411199. https://pubmed.ncbi.nlm.nih.gov/356411199. DOI 10.1093/ADGN/CAC154. 5. Chiruing-Suk et al. Diets for Weight Management in Adults with Type 2 Diabetes, an umbrella review of published meta-analyses and systematic review of trials of diets for diabetes remission. Diabetologia. 2022, 65, 114-36. PMID 3479637. https://pubmed.ncbi.nlm.nih.gov/3479637. DOI 10.1007/S00125-021-05577-2. 6. Nod CE et al. Low carbohydrate versus balanced carbohydrate diets for reducing weight and cardiovascular risk. The Cochrane Database of Systematic Reviews. 2022, 1 CD013334. PMID 350884007. https://pubmed.ncbi.nlm.nih.gov/350884007. DOI 10.1002/1465185.cd013334.pub2. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.